Recently, we published a paper entitled "Yes, we should abandon pre-treatment positional testing of the cervical spine" in Musculoskeletal Science and Practice. In this video, I will tell you something about this publication. After cervical spine manipulation, the estimated incidence of major adverse events ranges from 1 per 50,000 to more than 1 per 5 million. In a recent review, the most frequently described major adverse events associated with cervical spine manipulation was found to be craniocervical arterial dissection. However, the association between cervical spine manipulation and vascular major adverse events is likely due to patients with headache and neck pain, being the first pre-ischemic symptoms from craniocervical arterial dissection, seeking care before their stroke. Although a causality between cervical spine manipulation and major adverse events, in particular craniocervical artery dissection, is not likely, it is important that manual therapists try to prevent every potential major adverse event caused by vascular or other pathologies. With regard to the prevention of major adverse events, identifying a possible vasculogenic contribution to the complaints is important. Therefore, the patient interview is essential for identifying potential risk factors, red flags and contraindications. Positional testing for vascular insufficiency is often used by manual therapists as part of their pre-manipulative screening protocols. The validity of these tests and the added value to the patient evaluation has been questioned and discussed for decades. However, the tests continue to be taught to some students, carried out in daily clinical practice, and recommended in several practice guidelines. In this article, we argue that, from a professional perspective, the use of the VBI tests cannot be recommended. The diagnostic accuracy of the VBI tests was systematically reviewed in 2013. In pre-manipulative screening procedures, we aim to identify patients with a possible risk of complications. Pre-manipulative tests are used as an add-on test in the diagnostic process. When there are no signs of VBI or other contraindications for manipulation, these tests are performed to filter false negative results in the patient interview. Because it is important to prevent false negative results, the sensitivity of these tests should be high. Sensitivity ranged from 0 to 57%, indicating a low sensitivity. The aim of the VBI test is to unilaterally compress an artery to test the collateral blood supply. Because the tests are not able to consistently produce a decreased blood flow in the contralateral vertebral artery, the underlying mechanism of the test may not be a valid construct, because the collateral circulation will not be challenged and tested. The lack of sensitivity of these tests is also supported by several cases of cerebrovascular accidents associated with manipulation of the cervical spine, in which a VBI test was performed without a positive test result. VBI tests do not have a role in assessing the risk of serious neurovascular pathology, such as cervical artery dissection. Moreover, the signs and symptoms associated with VBI are clear red flags for any treatment by a manual or physical therapist. In the case of an expected vasculogenic contribution to the complaints, VBI testing seems not to be prudent and might even harm the patient. The patient interview is crucial for detecting these symptoms of VBI. Our conclusions are that the VBI tests do not seem to be important in the pre-treatment screening, and that the rationale and the value of the VBI tests should be questioned. A negative VBI test can easily be wrongly interpreted as safe to manipulate. The use of the VBI tests cannot be recommended and should be abandoned.